So this afternoon, I'm going to share with you some of my thoughts about hyperparathyroidism. What I'm going to cover is some of the additional surgical benefits, some of the surgical options, and then talk about some patient outcomes. And of course, the video of the rhinoceros. So in the United States, hyperparathyroidism is very common, 100,000 new cases each year, thought to be present in 1% of the general population, perhaps up to 2% in older patients. More common in women. It's the most common endocrine disorder after diabetes and thyroid disease, and is the #1 cause of hypercalcemia in both the outpatient and inpatient setting. So many of us are familiar with the benefits of treating hyperparathyroidism with surgery, including the improvement in renal function, bone density, and the neuropsychiatric symptoms. But I want to call your attention to a couple other reasons why we should consider doing surgery for these patients. There's a great study which shows that parathyroidectomy reduces suicidal thoughts and risk. And this study comes out of Germany, where they did a prospective multi-center study. And they surveyed patients with this questionnaire which focused on suicidal thoughts. And they had a control group of patients with benign thyroid disease who also were undergoing a surgical procedure. And you can see preoperatively the patients with hyperparathyroidism had a much higher percentage of suicidal thoughts compared to the thyroid disease group. And after surgery, the parathyroid patients would go back to the baseline similar to thyroid patients. So it clearly shows that parathyroidectomy does improve or reduce suicidal thoughts. Doing parathyroidectomy will actually improve insomnia and sleep. This is a study that we did at Wisconsin when I was there, when we measured the clinical insomnia score of patients both pre and post-surgery, and we defined clinical insomnia as moderate or severe insomnia in this group. And we found that before surgery, the mean score was close to 10, and that reduced below the levels of severe insomnia after parathyroidectomy. Parathyroidectomy also relieves heartburn. This is a study that we did, published in Surgery 2012, where we used a validated heartburn questionnaire, and patients were given this both pre and post-operatively, and you can see that the overall score for heartburn was pretty high preoperatively, which was cut in half after parathyroidectomy. And if you note, in every single category in this heartburn questionnaire, there was a reduction from pre to post-op after parathyroid surgery. As we all know, patients with hyperparathyroidism, when treated with surgery, have an improvement in their quality of life, and there's many studies showing this. But I want to highlight one study that we did that focused on patients with even mild hyperparathyroidism. And this was published almost a decade ago, where we used the SF-36 survey and administered to 174 patients a week before surgery, a week after surgery, and a year after surgery. And these are the results looking at the changes after 1 year. And what's notable is that you can see in every category in the SF-36 patients improve, and at the way right is the total physical composite score, mental composite score. So the dark green bars represents the improvements in patients with classic hyperparathyroidism, which you can see there's significant improvement. But in the lighter bars, those are patients with mild hyperparathyroidism. So you can see that they have even a greater improvement in quality of life than those with classic symptoms. So it really shows that even patients with mild disease perhaps even benefit more symptomatically from doing an operation. Much data shows that it prolongs survival, reduces cardiovascular incidence, and is very cost efficient. And many of us are familiar with these results, that patients send you letters like this after surgery. I want to tell you how great I feel after my parathyroid surgery. I feel like a new person. I never realized how bad I really felt prior to my surgery. I have extra energy to spend, and Don, my husband, has commented on the new me several times. So these are the great benefits of doing parathyroid surgery. And unfortunately, especially in the United States, patients are not always diagnosed. So this is a study that we just published last year in the Annals of Surgery, where we had the ability to look within our health system at the electronic medical record and and look at a series of patients seen at our institution, almost 700,000 patients who had at least one visit or hospitalization at UAB Hospital. And of those, we found about half of those patients, 300,000, had at least one serum calcium level checked. And about 10,000 of those patients had an abnormal calcium level. So the next test with an abnormal calcium, as we mentioned, should be a PTH, but surprisingly less than a third of patients at our institution had the proper testing to diagnose hyperparathyroidism. And there were many reasons this happened when we looked at the medical records. Sometimes hypercalcemia was attributed to something else that really doesn't cause hypercalcemia, or sometimes they just repeated the labs and got a normal one and therefore ignored the first abnormal one. And we all know parathyroid surgery, especially in 2018, is very safe. It's an outpatient procedure. Operation usually takes less than an hour, and we tell our patients just take it easy for a week, no heavy lifting or exercise, but after a week you can do anything, and many patients do not even take any pain medication after surgery. So after telling you what the benefits of doing surgery is, we have to ask what is the best surgical approach. So many people do a unilateral or a targeted, minimally invasive, focused, or concise approach, which usually involves getting image-guided localization, usually with the sestamibi, ultrasound, or CT. And if you see that single gland, you resect it, and you use intraoperative PTH, or you do a highly selected group who you think really has a single adenoma, and the results with that approach are outstanding. On the other side, some people prefer a bilateral approach, which is sort of the old gold standard where you visualize and identify all 4 parathyroid glands and you resect the abnormal ones. And when you do a bilateral aspiration, as you know, you can still use any operative adjuncts. So in comparing these two procedures, what is the best approach? And I would say in the area right now of personalized medicine, where we really focus on individualizing patients and coming up with individual approaches, I would argue that it really depends on the patient. So if you have a patient with a pretty elevated calcium and a high PTH and a positive imaging study, you're probably going to go with a unilateral approach. Conversely, if you have a patient with MEN1 or with mild hyperparathyroidism, both diseases would predispose you to multi-gland disease, you're probably going to choose a bilateral approach. Or nowadays, more and more patients are actually choosing to have a 4-gland exploration. And in fact, it's very common in my clinic, and when I see a patient, even if they have a localized gland, and I say, well, we're going to do a targeted approach, and they say, well, doc, aren't you going to look at all 4 of my glands? I've read on the website that that's what you have to do. And so then you end up doing a 4-gland exploration because of patient choice. So whatever choice you go with, I just want to show you a little bit about my approach. And I am a big advocate of doing radio-guided parathyroidectomy. I do it on all my patients. And so what happens is once a patient is decide to have surgery on the day of surgery, in the pre-op holding area, our nuclear medicine people come up with this canister containing an injection of 10 millicuries of sestamibi, half the dose that we use for scanning. I don't obtain a scan that day, but we give it right at the bedside before going back to the operating room. And we actually put a label on the patient, so we make sure that the patient received this prior to going to the operating room. And then once in the operating room, I set a background count on the thyroid isthmus with a standard gamma probe. We use this one from Ethicon, but you can use any of the gamma probes used for sentinel node biopsy. And so we set a background on the thyroid isthmus, and that can be done through the incision or even before you make incision. And if you want to, you can utilize it to locate the parathyroid gland. A lot of times you can just find it without putting the probe through the incision. And for those of you who do sentinel node biopsy, it's a very different reading that you're looking for parathyroid. If you look here on the monitor, the background count on the thyroid isthmus is 190. So the counts are much lower than what you see with sentinel node. and the count of the abnormal parathyroid gland in situ is only 341, so a slight increase in the counts. And that's why when surgeons use this for the first time, if they have experience using sentinel node, it's very, very different because you're looking for much lower counts. And then probably I think the most useful part of using the gamma probe is immediately if you take the resected tissue and put it on top of the probe, and its ex vivo count is greater than 20%. So you take that ex vivo count and divide it by the background count on your thyroid isthmus, and it's greater than 20%, that is definitely abnormal parathyroid tissue. You don't need to confirm it any other way. So we never do frozen section. And basically, the higher the percent, actually, the greater chance it's an adenoma versus hyperplasia. And then, of course, we do it through a small incision like this, and which heals very well, that you can hardly see a week later. So that's, I utilize radioguided parathyroidectomy for all my cases, and I'll describe a little bit how I use it in both primary mediastinal parathyroids and with secondary tertiary hyperparathyroidism. So going back to 2001, I've operated on almost 2,300 patients with hyperparathyroidism using the gamma probe. And of those, a little over 2,000 had primary hyperparathyroidism. And of that, about 1,500 I did a minimally invasive approach, a unilateral approach, so that's about 76% of patients that I've operated on. Of those, 16% had previous neck exploration, which I think is, the gamma probe is very useful in those patients. And you can see the age ranges from 10 years old to 92 years old. With most patients have elevated calcium and PTH levels, but we do see a number of patients with mild disease. This is an example of a patient where the gamma probe can help you with placing your incision and where to go. This is a quadriplegic patient who weighs about 400 pounds. And he was having recurrent urosepsis from kidney stones. And he had a right upper parathyroid adenoma that we could easily locate with the help of the gamma probe. About 14% of my patients had ectopically located glands in the thymus and the thyroid and carotid sheath. The glands range from 40 milligrams to 23,000 milligrams. And there are pretty good opera results with 6 months normal calcemia reached in 99% of patients. But it's important to note, if you follow patients long enough, there's about a 15% chance of recurrence at 10 years. So important to keep long-term follow-up. And like I said, almost all the patients go home the same day. Now, as I mentioned, 76% of my patients with primary undergo unilateral procedure, which means that the remaining have a bilateral exploration. So why do they? Well, sometimes they have negative localization, sometimes patient preference. As I mentioned, with multiple endocrine neoplasia, they're going to have multi-gland disease, so you do a bilateral approach. And sometimes you do a bilateral approach because you're doing a total thyroidectomy or a thyroidectomy as well. Now, it's important to note, I said I use the gamma probe in every one of my patients, including those with negative sestamibi scans. So I'm going to say that again because this is something that people don't recognize, is that if you have a negative sestamibi scan, you can still use the gamma probe because the technetium is still taken up by the parathyroid gland. And the reason why it's negative on a sestamibi scan is because you have a camera several feet away trying to image a parathyroid gland, but when you have a gamma probe that's right in the incision, you can totally detect it. So we published this series a while ago showing that radioguided surgery is very effective in patients with negative sestamibi scans. This is an example of a woman who had a negative sestamibi scan who the gamma probe helped localize the undescended parathyroid gland. So we can make an incision up high, and there's the parathyroid gland right there. Now, another application for radioguided surgery is in patients with parathyroid cancer. This is a patient of mine who had had 6 previous parathyroidectomies for recurrent parathyroid cancer. And the gamma probe was very helpful in dissecting through the tremendous amount of scar tissue to find where the recurrence was. And it was about a 2-centimeter recurrence embedded in a whole bunch of scar tissue. Radio-guided surgery is also helpful for patients with mediastinal parathyroid glands. And so our approach for most patients with mediastinal parathyroid glands that are too low to reach from the neck would be a video-assisted thoracoscopic surgery. So I think we published the first initial report of using radio-guided surgery with this approach in 2005 with our thoracic surgeon colleagues. This is an example of one of the patients in the series. So you can see that this sestamibi scan shows a focus of activity right there in the mediastinum. So, but it's important to note that it was present on early imaging, but not in the late imaging. So I tell our trainees always never look at the report, always look at the scans yourself. Because in fact, this report, you can see the reading was an adenoma is not identified. So clearly missed by the radiologist. That patient also had a CT scan that was read as negative because the referring doc decided to get another imaging study because this one was negative. Although that CT was read as negative, the parathyroid gland you can see is right there. Where it would be in the thymus. And so what we did is we took this patient to the operating room for a video-assisted resection. And so what you see here is the patient's left side chest, and the head is up here, up at the top here, feet down here. And what we do is we utilize 3 ports through the chest wall. And our initial case was done with one of our thoracic surgeons. And you can see this is looking inside the left chest. We have a double lumen tube, so the lung is collapsed. And our thoracic surgeon is telling me, we don't need a gamma probe. I can see the parathyroid gland. It's sitting right there. We just take it out. And I said, well, hold on. Let's just put the probe in and see where it is. And in fact, that is not the parathyroid gland. The parathyroid gland is way down here. So what we did is we used this laparoscopic gamma probe. And here it is, applied inside the patient, showing indeed that the parathyroid is located lower in the mediastinum and that we needed to change where we're going to resect. So typically we do these operations with the harmonic scalpel to resect what is going to be a parathyroid in the thymus. And here's just an example of us then using the gamma probe to show that indeed there's a parathyroid adenoma within the thymus. Now, radio-guided surgery is also useful for patients with secondary and tertiary hyperparathyroidism. And as we just heard previously, this happens when you have long-standing secondary hyperparathyroidism and the patient gets a renal transplant. Although most patients resolve their hyperparathyroidism, about 2 to 3% have persistent hypercalcemia and high PTH levels. So this is a picture of our hospital at UAB, and we're a huge transplant center, so we see a lot of patients with tertiary hyperparathyroidism. Now, when I was at Wisconsin, we actually looked at our results with surgery for tertiary hyperparathyroidism, and we had noticed a marked decline in the number of patients we were seeing with the introduction of cinacalcet. So when we looked at our series more recently, we found there were 600 patients with tertiary hyperparathyroidism, but the majority weren't even getting treated anymore. That the nephrologists were watching the patient, and even though the ones that were treated, 36% were treated, the vast majority were being treated with cinacalcet, and very few were referred for parathyroidectomy, which is really sad for us to see. Because when you looked at the outcomes of these patients, when you compared the patients in this series who had parathyroidectomy versus patients treated medically, you can see with the serum calcium on the left, calcium is better controlled with parathyroidectomy, and PTH levels are much better controlled with parathyroidectomy as shown on the right. And so when we audited these records and showed our nephrologist, and in fact, this was an interesting finding. We then looked at the patients and their kidney graft survival. And of course, our nephrologists were worried about this. And if you looked at the graft survival here on the y-axis, the years after transplant, patients with tertiary hyperparathyroidism were treated with surgery, parathyroidectomy, had a longer graft survival than those treated medically. So it really made the argument to them that the practice they were doing was wrong, and they totally switched, stopped using cinacalcet, and then started to refer all those patients to surgery. And as I mentioned, radio-guided surgery is very helpful for patients, so we use it for these operations. This is, I think, the first initial report using radio-guided surgery back in 2003. And what we found is that the operation actually can go much faster if you use radio-guided approaches versus non-radio-guided approaches in these cases. So in conclusion, I think parathyroidectomy in 2018 is an outpatient procedure with minimal risk. It's effective, improves quality of life, prolongs survival, prevents complication. That, in my opinion, all patients with hyperparathyroidism should be referred for possible surgery. And the surgical approach is really patient dependent in the era of personalized medicine. Thanks so much for your attention today.